Okay, dear friends, it's a great honor for me to be as president of the World Society of Arrhythmias, introducing my dear friend, but Professor John Camm, for this last webinar of my presidency of the World Society of Arrhythmias. John is a friend of the Latin American people from a long time, and we are very proud having him being the last of our webinars in the area. SADC is joining us, and SAC, the Argentinian Society of Cardiology, also. So I want to thank the societies to participating to distribute this presentation all around the Latin American countries, probably. John, SADC is also honored to mention you as an honorary member of the Argentinian Society of Pacing and Electrophysiology. So you are going to get a diploma because it's very important for us and for you to be an important member of our group. And I want to go, yeah. So also we have present or attending the president of SADC, the people of SAC, and I want just to go to a topic that we were discussing if it was interesting or not. We all know that atrial fibrillation is the more frequent arrhythmia that we treat as cardiologists and as electrophysiologists. And our main and important problem is that really anticoagulation became a topic that is one of the most important parts of the treatment of patients with atrial fibrillation since the last 20 years. John is a real expert, and he will put us on what's the future on the treatment of atrial fibrillation with anticoagulants, and he is trying to put us in order at what is the best or more important advances in the topic. Dear John, go ahead with your presentation, and after we make some questions and try to share with you this presentation. John Camm.
Well, thank you very much, Oscar. I must say I'm really pleased that I've been asked to give one of the World Society of Arrhythmias webinars. And today I've been asked to talk about what is the future of anticoagulation for patients with atrial fibrillation. I'd like to say hello to all of you who are listening to me. Before I start, of course, I have to show you that I have some potential conflicts of interest. Most of them are, I think, fairly irrelevant, but please notice that I have worked with a number of companies, many of which have got interests in the area of atrial fibrillation and anticoagulation. Please bear this in mind. I want to start at the beginning of the new era of anticoagulation. You'll all recall that we have 4 so-called direct oral anticoagulants, or DOACs. These were investigated each with a trial that compared the DOAC with dose-adjusted warfarin. And the results of these trials are summarized on this slide. We can see with regard to the efficacy endpoint that several of these DOACs outdid the vitamin K antagonists. We can also note that with regard to the major safety outcome of major bleeding, that several of the DOACs also did much better than vitamin K antagonists. Now, in summary, in a large meta-analysis, Christian Ruff provided this information. Firstly, that hemorrhagic stroke and intracranial hemorrhage were about 50% reduced. Secondly, that mortality was reduced a further 10% compared with vitamin K antagonists, and that ischemic stroke was trending towards a reduction, but was not significant. Unfortunately, there was a 25% statistically significant increase in major bleeding. A later meta-analysis of these 4 trials demonstrated that patients, as they aged, got more benefit with regard to the comparison between the NOAC and warfarin with respect to the outcome of stroke and systemic embolism. This was not as well seen with the low dose of NOAC, but of course major bleeding was very much reduced with the lower dose of bleeding, but it was, for the most part, through all ages, there was no significant, even with standard dose NOACs, of an increase in bleeding with NOACs compared with warfarin. Now, some people therefore decided that we should try and change all the patients who were taking vitamin K antagonists to a DOAC drug. And this, for example, is a specific guideline from NICE in the United Kingdom. If you read the top part, it says that for adults with atrial fibrillation who are already taking a vitamin K antagonist and are stable, they should continue their current medication and discuss the option of switching treatment at their next routine appointment, taking into account, etc., the patient's time in the therapeutic range. Now, I'm not sure that that advice is really sound, because at the European Society of Cardiology, we had a report of what is called the FRAIL AF trial. And this enrolled patients who were taking vitamin K antagonists. They were stable on the vitamin K antagonists. They were elderly, 75 years or older. And you can see the primary outcome, which consisted of bleeding, that's major bleeding, and clinically relevant bleeding, that it was excessive in those who switched to the DOAC compared with those who stayed on a vitamin K antagonist. Interestingly, thromboembolic events were increased in those who changed to the DOAC, although that was not statistically significant, and there was no difference in all-cause mortality. So we have to wonder whether in the future, if we have patients who are stable on warfarin or vitamin K antagonist, should we leave them and not change them? Now, because of the results of all of these DOAC trials, it's not surprising that when it comes to anticoagulation, and here we see the European Society of Cardiology flowchart in their guidelines, that if we are choosing between an anticoagulant of a NOAC variety or a vitamin K antagonist, the ESC recommends that we do use a NOAC drug. But look more carefully at this flowchart, because I think there are some problems. And I think one of the big problems is this confusion with the CHADS-VASc score, because as you know, female gender itself doesn't really make much difference to risk. And for that reason, we are now beginning to talk not of the CHADS-VASc score, but of the so-called CHADS-VA score. In other words, we're forgetting all about the sex category, the female gender, and simplifying the score. So now we can think of this flowchart as being 0, meaning no anticoagulant, 1, meaning that it should be considered, and 2 or more, meaning that it ought to be indicated, provided there's no definite contraindication. But the big problem we have, I think, with all of these guidelines is this intermediate category of 1. Let's have a look what happens in the real world. We can see on the right-hand side of this slide some results from Garfield. Here you see the CHADS-VASc score, 0, 1, and 2 or greater. And even in patients who shouldn't be anticoagulated, you can see that about half are. Now, we don't really know why this is. It's probably because the physicians are trying to be especially careful that the patient shouldn't have a stroke. And there will be some patients that are not within the CHA2DS2-VASc score, like hypertrophic cardiomyopathy and so on, which has only recently been put into the score. If we look at those with a score of 2 or more, we can see that it does show that about a third of patients are still not anticoagulated. A lot of them are taking a monotherapy with aspirin, but about 10% are taking nothing at all. These are generally old patients or patients who are sick for one reason or another, but amongst them are still many patients who really should receive an anticoagulant. It's this middle group, however, that is more challenging. And you'll see that the guidelines say that we should do further assessment of the risk of stroke, for example, looking at age and so on. Well, this has been developed much more by a physician known as Sulzgruber, and this is the scheme that he recommends. It looks a little bit complicated, but if we take patients with this intermediate score of 1, the first thing we should do is look at the bleeding risk. And you can see I'm talking about 2 bleeding risk scores here, HAS-BLED and ORBIT. If they're low, as on the right-hand side, then the thromboembolic risk probably does well exceed the bleeding risk. And provided that the patient prefers, then they should have an anticoagulant and probably a DOAC drug. On the other hand, if the HAS-BLED or ORBIT scores are high, in other words, the bleeding risk is high, then the thromboembolic risk is probably less than the bleeding risk, and we shouldn't anticoagulate the patient. That is, unless there are other thromboembolic risks. And on the left of this slide, you can see a whole range of other factors that can be taken into account. For example, age over 70 is getting nearer to a CHA2DS2-VASc score of 2. Persistent atrial fibrillation or high burden atrial fibrillation is another risk factor. Renal malfunction is another risk factor. And even anatomical features such as non-chicken wing left atrial appendage morphology. Well, we should look to see if there are other thromboembolic reasons why we should anticoagulate. And we should also look to see whether we can modify bleeding risk so that the advantages of the anticoagulant outweigh bleeding disadvantages. Now, I did mention more than HAS-BLED score because many guidelines are now beginning to recommend that we use different bleeding scores. The ORBIT is one. It comes from a large American registry. And you can see that the features are age over 74, a reduced hemoglobin level, anemia, a bleeding history, impaired renal function, or concomitant treatment with antiplatelets. It's not an easy score to use because you obviously need some blood test results. Another score that has recently been advocated is the so-called DOAC score. Now, this is more complicated. It's derived originally from the RELY trial data, but then tested in what's called the combined AF data of all the trials and in the Garfield registry. You can see that it involves looking at age, various scores for increasing age, looking at renal function, looking at a number of clinical factors that we're familiar with, looking at co-administration of antiplatelets and non-steroidal anti-inflammatory drugs, and so on. The top score is 10, even though you could obviously get far more than 10 by adding up these points. If we look at the results, we'll see that a low score has a bleeding risk over 1 year, which is about 1%. But the high score of 10 or more has a bleeding risk of about 8%. In the real world, the absolute numbers are lower, but you can see that it does distinguish low risk from higher risk. And the C statistics are much better than they are with the HAS-BLED score. Now, the next feature that we are considering more and more is how relevant is atrial fibrillation burden to justify anticoagulation. And this study is helpful in thinking about that. It was a simple study, a Zeopatch recording for a couple of weeks, identifying the percentage of time that patients were in atrial fibrillation and the proportion of patients who were at that AF burden. They were then followed and their stroke risk was evaluated and expressed in terms of per 100 patient years. If we look, we can see that we could divide the patients into tertiles. The overall risk, as you can see, is just less than 2%, hardly justifying anticoagulation because we really need a rate of about 2% or more. And the first tertile is a very low risk. The second tertile, up to about 20%, is also too low to consider anticoagulation. It's only really the third tertile of an AF burden of more than 20% that justifies using an anticoagulant. Here's the usual threshold for anticoagulation. Now, we've had no formal trials on this until the NOAA AFNet trial. It wasn't actually just looking at very low burden atrial fibrillation. It was looking at patients who had atrial fibrillation that was revealed because they had a pacemaker, ICD, or an implantable cardiac monitor. The NOAA trial compared a placebo against edoxaban in a double-blind, double-dummy way. The outcome was systemic embolism, stroke, or CV death. Artesia is a trial comparing aspirin with apixaban, similar design, but the outcome is slightly different. Stroke and systemic embolism, no cardiovascular death. And you can see in this trial, patients who had what's called in North America subclinical atrial fibrillation more than 24 hours were not admitted to the study. Now, we have the results of NOAA, but we're still waiting for the results of Artesia. The results of NOAA were intriguing because we can see that the stroke and other embolic events were numerically less in those anticoagulated, but it wasn't statistically significant. On the other hand, bleeding was statistically more with edoxaban than it was with placebo. So the advice that we're currently following is the same as previously. If we see atrial high rate episodes, if the patients had a stroke, then we generally anticoagulate them. If not, we look for clinical atrial fibrillation. If we find it, we anticoagulate the patient. If not, we keep looking. Now, I think there is an exception. If there's a very high CHA2DS2-VASc score, we probably will move towards standard anticoagulation. Now, let's turn our attention to ablation and whether we should anticoagulate patients who've undergone catheter ablation. Here's a meta-analysis of many observational studies, about 11,000 patients altogether. And if we look at thromboembolic events, we can see, if we look at major bleeding rather, we can see that there's a definite and expected reduction in major bleeding if we don't anticoagulate the patients after an ablation procedure. That is excluding the first 2 or 3 months. And interestingly, the thromboembolic events were not statistically different between those who were anticoagulated and those who were not. We have a trial which is almost completed, and I'll show you it in a moment. But currently, the advice is that we should consider long-term continuation of systemic anticoagulation beyond the first couple of months, according to the patient's stroke risk profile, and not on the apparent success or failure of the procedure. irrespective of the finding that we all know about, that if CHA2DS2-VASc score is very low, or if there's very little AF, the risk of stroke is minimal. So currently, following an ablation, we use this kind of scheme. If the patient is ablated and we assess the stroke risk, if the stroke risk is relatively high, we should anticoagulate the patient. If it's low, we should monitor the patient for recurrence of atrial fibrillation. If we find it, particularly if it's prolonged or if it's asymptomatic, we should probably anticoagulate the patient in a standard way. But if it's symptomatic, we can consider using pill in the pocket or PRN use of anticoagulants. Either way, we must continue to monitor the patient for the recurrence of atrial fibrillation. We do have a trial underway, the so-called OCEAN trial. It's almost concluded. As you can see, patients enter this trial if they are 12 months post-ablation and they don't have any atrial fibrillation. They're randomized to aspirin or to rivaroxaban, and they're followed for some 36 months. This will give us very good information on whether we should anticoagulate patients and which patients following a successful catheter ablation. Now we have new anticoagulants on the horizon. You remember that heparin, for example, and the first of the vitamin K antagonists came onto the clinic in the late 30s, early 40s. And by 1990 and certainly by 2008, we had oral factor II inhibitors. In about 2010, we began to see the factor Xa inhibitors. But now we're beginning to see the so-called factor XI inhibitors. Now, there are quite a few of them, as you see. But first, why are we interested in these factor XI or factor XIa inhibitors? And it's because we can think of the coagulation cascade as two separate cascades. One which is triggered by tissue in the vessel wall, so-called tissue factor, which activates factor VII and this so-called extrinsic pathway. And this is responsible for hemostasis. In other words, clotting heals the vessel. But there is another pathway which is stimulated by, for example, foreign objects within the vessel wall. And this is the intrinsic pathway within the vasculature, I should say. And that's the activation of factor XII and then factor XI going through and producing thrombus. Now, the production of thrombus and the production of hemostasis are two separate processes. And if we inhibit factor XI, or the active form of factor XI, where we can prevent thrombosis whilst not affecting hemostasis. So we can think of all of these anticoagulants as we move from left to right, the likelihood of bleeding becomes less and less, whilst they're all effective at stopping thrombosis. So the factor XI inhibitors are new agents that we're beginning to investigate. Here we see that they come in many forms. They can be antibodies, they can be small molecules, they can be antisense oligonucleotides, and there are some other varieties. But of these, the antisense oligonucleotide was the first one to be described. It's given subcutaneously, but it takes weeks or months to be active because it stops the formation of factor XI in the liver. Now, its advantage is it's not affected by renal problems or by hepatic metabolism or drug-drug interactions. But it's relatively inconvenient. And we should look at the small molecules Now, the small molecules you take just like a factor 10A inhibitor, they work rapidly and they are excreted rapidly. Unfortunately, they can be influenced by renal excretion, CYP metabolism, and drug-drug interactions, but they can also be given intravenously. Another agent type is the antibody. Now, the antibody is very interesting because it is slow, relatively rapid to act, but it lasts for a long time. And therefore, you can give it on a monthly basis. If you do that, it targets the protein, makes the coagulation factor inactive, and it's not vulnerable to all of these problems. Now, we've only had one clinical trial reported in patients with atrial fibrillation, and that's the Pacific AF trial. This is a relatively short trial, only 12 weeks in duration, and it compared asundexian, a small molecule, 2 doses of this, against apixaban. It was only to look at primary safety, in other words, bleeding rates. It would perhaps explore efficacy such of parameters or outcomes such as stroke, but it was not designed to do that because there are only 250 patients per group. The results were these. You can see the ISTH major bleeding and clinically relevant non-major bleeding by this color. And you can see the rates of bleeding for asundexian, the low dose, the higher dose, both doses, were significantly less than a rate of bleeding for apixaban, which is the safest of the DOAC drugs. So we can, I think, be confident that these drugs will significantly further reduce bleeding. Now, we have other trials which are ongoing at present. For example, we have trials which are comparing factor 11 inhibitors with DOAC drugs in patients at high risk of stroke. They involve up to 20,000 patients and may last up to 3 years from now before we get results. We have other patient groups, such as those who cannot tolerate approved oral anticoagulants, where the comparison is between factor 11, 11A inhibitors and placebo. Much smaller trials lasting up to a year less than the trials against DOAC drugs. Here are all those trials, and I've shown you, there are 6 altogether, and I've shown you already the results of the Pacific AF trial and the Azalea trial with abelacimab against rivaroxaban will be given at the forthcoming American Heart Association meeting. You can see the other 4 trials, 2 of them against DOACs and 2 of them are against placebo. Now, it wouldn't be right for me to forget when talking about antithrombosis for patients with atrial fibrillation, the issue of the left atrial appendage closure device. Now, these were first introduced, as you can see, in 2002. And we're over 20 years since that first introduction of these devices. And we know from 3 trials, PROTECT AF, PREVAIL, and Prague 17, that stroke rates are very similar. Ischemic stroke are trending towards being perhaps adverse, but hemorrhagic stroke is much less, as is procedure-related bleeding, and even mortality, less with the left atrial appendage closure device compared with anticoagulants. But these trials did not feature many patients who were taking NOAC drugs. The guidelines currently, however, are quite encouraging. They say that left atrial appendage occlusion may be considered for stroke prevention in patients with AF and contraindications to long-term anticoagulant treatment. That's the ESC 2020 guideline. The latest of the guidelines is the SKY HRS guideline in 2023, and that says transcatheter LAAC is appropriate for patients with non-valvular AF with high thromboembolic risk who are not suited to long-term OAC. So there are a whole range of potential circumstances in which the left atrial appendage closure thromboprophylaxis is better than anticoagulation. For example, patients who have recurrent bleeding, those who have strokes despite anticoagulation, those who don't take the medication, etc. So with that in mind, I just want to conclude by saying that DOACs are currently the best of the anticoagulants we have for AF-related stroke prevention. That when we are assessing patients, we should now be using the CHADS-VA score. We need to think of more than simply the CHADS-VA score when the score is 1. And we have to think of all the other possible risk factors for stroke. We know that there are some challenging issues like catheter ablation and device-detected atrial fibrillation, for which we have trials about to report or have just reported. And finally, we're very much moving towards factor 11 inhibitors, and it will certainly be somewhere to look very carefully for future management of atrial fibrillation. So thank you very much, Oscar, and thank you very much, everyone, for listening.
Thank you, John. Incredible and excellent presentation as always. And you put things in order as always. You know, we, as I said at the beginning, have a lot of atrial fibrillation patients in our offices, and we need to make decisions, and we need not to be so aggressive and not to take risks in many of these patients. And you are putting us in the situation that we should analyze all these cases. We have the opportunity to make you questions, and I will be from the audience getting them by the chat system. But I'll start making you a couple of use questions for typical things. One question is if we prefer any of the NOACs in renal failure patients, John. What do you think about that?
Well, we have to remember that all of the NOACs are to some extent excreted by the kidney. And therefore, we may have to select a specific dose, a dose reduction because of that. The one that's most excreted by the kidney, of course, is dabigatran. And I don't advise that we use that one at all in patients with renal failure. But the other three can be considered. I think of the other three, rivaroxaban and apixaban are usually thought best because they're only about 30 to 33% excreted via the kidney. And interestingly, these DOAC drugs, particularly the factor 10A inhibitors, seem to prevent progressive impairment of renal function. In other words, if we put patients on a vitamin K antagonist, their renal function will get worse much more quickly compared with putting them on a DOAC drug. Now, this result has been best demonstrated with the drug rivaroxaban. On the other hand, we know that bleeding rates in patients with renal impairment seem to be less with apixaban, noticeably less with apixaban than with warfarin, whereas with rivaroxaban, that was not seen in the so-called pre-approval trials. So I think we have one reason to think about rivaroxaban, another reason to think about apixaban. And I think in patients whose renal impairment is getting more and more serious, I would choose rivaroxaban, but in patients with moderate renal impairment, I would generally choose apixaban.
Thank you. Thank you for clarifying this bedside decision that we need to make every day. You know that, and that's the reason of the question. The other question I had to make you is, how frequent is to find clots in the atrial appendage in patients with NOAC?
Well, it's not frequent, but we know that NOACs doesn't completely prevent clots and thrombus. But on the other hand, it's usually because the patient is not taking the NOAC drug, or is taking a half dose, or is missing every week several days of treatment. And it's very difficult to monitor patients on NOAC drugs because all you have is the patient's word or a carer's word that the patient is taking the drug. You can look at the blister packs or whatever and see whether it looks as though the patient is taking the drug. Most of us are not doing blood levels, and anyway, blood levels will only tell you about what happened yesterday and today. They have practically no relevance about a week ago, unlike an INR test, for example. So even in patients, however, who do take DOAC drugs, there is thrombus formation in the left atrial appendage. It's probably of the order of a small percentage. But on the other hand, there's more smoke that you can see than that. You probably see smoke in about 5% of patients who are taking DOAC drugs. And we know that in patients who, for example, have a left atrial appendage we can...
No, it seems it was disconnected, John.
Combination of left atrial appendage closure and perhaps low-dose anticoagulation.
Are you listening, John?
Yes.
Okay, because there was some little disconnection and we don't see you. Now we see you again. Oh, thank you so much. That's important. And let me make you one more question and then go to the attendees. Is any contraindication of using NOACs besides the easy bleeding patient?
Any contraindication?
Yes.
I don't think there are many widespread contraindications. Obviously, if patients bleed, that's a contraindication, particularly if they have angiodysplasia or if they have cerebral amyloid angiopathy, for example, or even microbleeds. Many neurologists would contraindicate the patient for anticoagulation. That's not the ESC recommendation, however. There are clearly patients who, following a major bleed, physicians are very reluctant to anticoagulate with anything. For example, intracranial hemorrhage or intracerebral bleeds, they are not likely to want to use anticoagulants, although some are, particularly after about 30 days. Some physicians are quite happy to anticoagulate the patient again. And we have lots of ongoing trials looking at that kind of patients. Now, in patients on hemodialysis, there's very little good quality evidence that they can be treated effectively with any form of anticoagulation, including NOAC drugs. And so, again, that is an area of a lot of ongoing research, which involves not only drugs, but also left atrial appendage closure devices. So there are a whole range of things that we have to consider when we think about whether we can use an anticoagulant, number one, and specifically, can we use a DOAC drug?
Thank you, John. One last thing from my part, and then I go to the Spanish aspects to change the language. But let me ask you, in acute coronary pain, yeah, you have a patient with an infarct and is getting some way of aspirin and blocking antiplatelets and all that things. When is necessary to use anticoagulation?
If the patient has atrial fibrillation, anticoagulation is necessary, full stop. So it's a question more about how often and how long you use the antiplatelet drugs. And over the last few years, the duration of antiplatelet treatment in patients already taking an anticoagulant for their atrial fibrillation, the duration of use of antiplatelets has been reduced. So, for example, dual antiplatelet therapy possibly only for a few days or a week or so, single antiplatelet therapy in addition to the anticoagulant up to 6 months or so. In patients at very high risk of vascular ischemic problems, then those can be lengthened, of course. You have a month of dual antiplatelet therapy or even 3 months, going up to a year with single antiplatelets. But after 1 year, I think most people are now in agreement that an anticoagulant alone is sufficient.
Thank you, John. I'll ask you to go to the little globe in your screen and change the language. So you're going to get the translation of the translator of the Spanish people, the Spanish speaking people. Yeah?
I can hear you, yes.
Okay. So, queridos amigos, let me go to Spanish. Queridos amigos, yo quisiera preguntarles, por ejemplo, el doctor Cueto tiene una pregunta, si la puede hacer.
Sí, cómo no. Hay una conducta que se toma con pacientes que uno interna, sea en plan quirúrgico o no, con necesidad, anticoagulados por vía oral, le suspenden la anticoagulación oral, lo pasan a la heparina, lo pasan de bajo peso molecular, y siempre me pregunto qué tan seguro es esa conducta. Si eso de suspender el anticoagulante oral y pasarlo a la heparina al paso de bajo peso molecular, le da seguridad de que no va a ser una stroke.
Very good question. I think that we should first remind ourselves that DOAC drugs are very rapidly acting and they have a very short elimination half-life. So usually, for most surgery, it is unnecessary to stop the DOAC more than 24 hours prior to surgery. In many cases, if the surgery is unlikely to be complicated by major hemorrhage, you probably don't need to stop the DOAC at all. You probably do the surgery on continued DOAC. If it's an operation where internal hemorrhage is quite possible, then you would want to stop the DOAC, given that the patient's renal function is normal, just 24 hours ahead. If they have abnormal renal function, of course, it takes longer for the DOAC to clear. And then you would need to stop it 2 days or 3 days, depending on the DOAC and the renal function. And then I think post-surgery, as soon as the surgeon is satisfied that hemorrhage is unlikely, you can immediately restart the DOAC. Now, there will only be a limited number of operations where you have to bridge with low molecular weight heparin. And I think major thoracic, major abdominal surgery, you might have a short period of bridging following surgery with a low molecular weight heparin, but many surgeons will go straight back to the DOAC. And I think we have to get rid of this, I think, a hangover from the vitamin K era, where we had to stop a week or so before surgery, bridge with low molecular weight heparin, have the surgery, restart the low molecular weight heparin and the warfarin, because it would take several days or even weeks to get back to the therapeutic range. So in brief, my answer is bridging only if necessary and for as short as possible.
Muchas gracias, doctor, y excelente exposición.
La próxima pregunta será del doctor Gan López, por favor. José,
está.
José estaba ahí. José, ¿estás? Voy a hacer una más yo, en todo caso, hasta que José se pueda conectar. John, usar dosis menores de NOACs. ¿Cuáles son las ventajas y desventajas en muchos pacientes?
Well, I think it's obvious if you use a lower dose, you will have less bleeding as a result of using the DOAC drug. But on the other hand, you will lose on efficacy. If the patient is unable to excrete the DOAC drug because of, for example, renal impairment, then obviously a lower dose becomes necessary. Or if the concentration of the DOAC is going to be increased by a drug-drug interaction, for example, with PGP inhibitors, then you will need a lower dose because you don't want to over-treat patients because the only gain from that is more bleeding without further reduction in stroke. So generally, I think that low-dose drug is to be discouraged unless it is according to the drug label. Now, I know that many people in the past, particularly because of the expense of the drug, have bought a month's supply and make it last 2 months. I understand why they do that, of course, because they can't afford the drug and they'd rather have a little of what does you good rather than not having any at all. But on the other hand, it's not good medicine to recommend that.
Bien, José Gan López, ¿ahora estás conectado?
Sí, I have audio but no video, no problem. Thank you, Dr.
Habla
Camm,
español,
for
por favor.
your excellent presentation. I have two simple questions. The first, how is your opinion about treatment in athletes, in sport, in patients with paroxystic atrial fibrillation, this in sports? The second is what do you think about treat in asymptomatic patients over 65 years old? Thank you.
Yeah, so also two very good questions. I think in sport, it depends on how dangerous the sport is. Clearly, if it's mountaineering or a contact sport, such as rugby, then I think that anticoagulation carries some danger. On the other hand, not anticoagulating will also carry danger, and it needs, I think, a very careful discussion between the physician and the patient under those circumstances. Non-contact sports, of course, I don't think matters very much. You might argue that a cyclist, for example, could fall off the cycle. There's also, I think, dangerous sports like motor racing and so on and so forth, where I think, again, if the patient has serious risk of thrombosis with atrial fibrillation, the patient should probably be encouraged to do some other form of sport if he can and will, which is not likely to put him in danger. But again, I think as physicians, we have a duty to explain to the patient just what the risks are of not taking an anticoagulant. So I think that's important. Now, your second question about asymptomatic patients over, I think you said over 65 or something. Well, I don't think symptoms is terribly relevant to the risk of atrial fibrillation. They are very relevant if you're going to base your treatment on the symptom. For example, with pill in the pocket anticoagulation, then unless the patient has reliable symptoms, i.e. knows when they go into atrial fibrillation, then it's difficult to use that technique unless you are going to use an implantable monitor or wearable devices that can tell the patient that he has atrial fibrillation. So, but for most patients, the presence or absence of symptoms, if they're taking daily anticoagulants, I don't think matters very much, except, of course, symptoms constantly remind the patient that they do have this problem and therefore does encourage the patient to take some treatment. Now, the age, of course, I think is important. 65 gives the patient a CHA2DS2-VA score of 1, and therefore comes into the range of where you should be considering anticoagulation. And then you would revert to that sort of algorithm that I showed you of looking what the thrombotic risk and what the bleeding risk is and trying to make an intelligent estimate of whether the patient will benefit from the anticoagulant or not. I must say it's interesting that in some communities, like I think particularly in the Far East, 60 or even 55 is the lower age for considering anticoagulation. But in Europe, we generally hold that there's very little, if any, risk below 65 unless the patient has other comorbidities that add to that risk. So the asymptomatic patient with no comorbidity except age, we generally don't recommend anticoagulation until they are at least 65. And many physicians will hold out until they're 75 if they don't have underlying other risk factors like diabetes, hypertension, heart failure, etc.
Thank you, Dr. Camm. Thank you.
Thank you, Jose.
John, una pregunta para que ya terminemos es, ¿cuán cerca estamos de considerar anticoagulación en pacientes con taquicardia auricular de corto o larga duración?
I don't think that we're looking much at what we in the old days would call atrial tachycardia, but certainly high atrial rate above 200 beats per minute. That is close to being, excuse me, equivalent to atrial fibrillation. The rapid atrial rates mean that the atrium is not beating effectively. And therefore, we can think of that as being a pseudo atrial fibrillation. And I think in that context, very rapid atrial tachycardia, we can think of it as being equivalent, just as we think atrial flutter is equivalent to atrial fibrillation. But for atrial tachycardias of, let's say, up to 160, 170 beats per minute, we generally do not think there is a specific risk related to, or specific stroke risk. Now that view would change, of course, if the atrium is large, if there's an obvious atrial cardiomyopathy underlying it, if there are lots of other pro-thrombogenic comorbidity. But generally, I don't think that anybody is trying to pick that up and do any studies on it. I think we are going to hear, of course, about the Artesia study at the American Heart Association. You remember that's the one twinned with the NOAA AFNet-6 study. And we'll hear the story from Artesia at the American Heart Association, just in a few weeks from now.
John, muchísimas gracias por esta excelente presentación, tanto desde el punto de vista científico como didáctico. La verdad que estamos muy contentos de la presentación. Esperamos que esté todo en orden y en nombre de la Sociedad Mundial de Arritmias Cardíacas, de la Sociedad Argentina de Cardiología, de la Sociedad Argentina de Estimulación, al nombrarte miembro honorario de la entidad argentina, estamos muy contentos y esperamos pronto poder volver a verte en estas reuniones. Muchas gracias, John.
Thank you, Oscar, and thank you everyone else for listening. Thank you very much to my interpreter. Thank you. Bye-bye, everybody.
Bye-bye.